Well, here we are with part 2 of hematologic emergencies on chapter 25. And of course, this is the second and final part of this particular chapter. We're going to pick up right where we left off. Our last discussion, we talked a little bit about sickle cell anemia, was the diseases that we started getting into. And we're going to start off this discussion with anemia. Of course, anemia occurs when the hemoglobin or red blood cell levels are lower than normal, and that's the definition of anemia. This condition is usually linked to some kind of underlying disease process or something else going on. It could be an acute or even a chronic blood loss issue as well. It may even be something to do with a production problem, a decrease in production or an increase in the destruction of erythrocytes or red blood cells. And there may even be some sort of a pre-existing hemolytic disorder going on there as well. Iron deficiency anemia is the most common type of anemia. Basically, the body doesn't absorb or have enough iron in it to be able to produce the hemoglobin necessary to transport the oxygen, which results in a form of anemia, and it's iron deficient anemia. Typical causes have to do with maybe gastrointestinal losses, maybe menstrual bleeding, also blood loss from frequent donations or diagnostic tests, and they can lead to a premature birth or low birth weight in children if not addressed and taken care of. Typically, there's a big, as mentioned, as the name implies, iron deficiency anemia has to do with the deficiency of iron. When the body destroys red blood cells or recycles the contents of red blood cells through the normal process of breaking them down in the liver or the spleen, they recycle a lot of that iron that was used in the original red blood cell, and it's reused in other red blood cells. However, if there's blood loss, there's no way to recycle that iron. So that's where we wind up with some iron deficiency anemia. You couple that with a decreased amount of iron intake, problems start to evolve. There are some inherited hemolytic disorders that can cause anemia as well, but these do it in a little more of an indirect way. In these conditions, the red blood cells maybe develop rigid and deformed membranes that just make them inhospitable. This can cause them to get stuck in small blood vessels, leading to thrombosis and rendering the cells ineffective. A deficiency of the glucose 6-phosphate dehydrogenase enzyme exposes red blood cells to infections, which can shorten the cell's effectiveness and lifespan. It's mostly found in African Americans. Also, problems with blood vessel linings or the presence of blood clots can disrupt the normal flow of red blood cells. There's some autoimmune disorders that can lead to the destruction of red blood cells by the body's own immune system. And certain infections can also cause hemolysis of red blood cells. The effects of fewer red blood cells combined with the thinner air of high altitude can also lead to hypoxia. Patients in these conditions may experience difficulty breathing and possibly even chest pain along with that. Most patients will typically complain of feeling worn down or having a complete lack of energy. They may have a feeling that they've overexerted themselves or overdone it. And they also may have signs of difficulty catching their breath, trouble breathing. Patients could also show signs of angina type chest pain due to a reduced oxygen supply to the heart. They may even have some changes in skin color, as well as low white cell counts and platelet counts, because nothing's quite working right. Management, of course, is going to be primarily supportive, and we're going to allow that patient to assume the position of comfort. Monitor closely for airway and breathing issues, check vital signs frequently, and of course in cases of chest pain, Make sure you apply the cardiac monitor, and it'd probably be a good idea to get a 12 lead as well, just to make sure that we're covering all the bases in case there is a cardiac event going on. Manage blood pressure accordingly and replace those fluids as needed, based on how the patient's presenting. If the patient develops an abrupt change in mental status, they get hypotensive, or there's other significant changes, you're going to need to really consider a rapid transport to the closest hospital to get that patient stabilized, because there may be something more significant or serious going on with them. Leukemia. Leukemia is a type of cancer that develops in the lymphoid system. It involves an increased production of immature and abnormal red blood cells, particularly white blood cells. Leukemia can lead to anemia, often associated with low platelet counts and a high white cell count, even though those white cells that are produced are not really productive white cells. Chemotherapy typically helps to reduce the number of those white blood cells that are present. However, during treatment, patients often experience frequent bleeding, bruising, and they are much more susceptible to infections which might present with a fever. Leukemia can be classified as either chronic or acute. Chronic leukemia tends to develop more frequently in individuals over the age of 65. However, in acute leukemia, the bone marrow is replaced by abnormal lymphoblasts completely. So in chronic leukemia, abnormal mature lymphocyte cells accumulate in the bone marrow, lymph nodes, spleen, and peripheral blood. This change, or these things, the presence of these, is often discovered completely by chance through a routine blood exam. Leukemia survival rates actually depend on several factors. One of them is the stage at which the disease is detected. If it's late stage, the survival rates go down. If it's early stages, there's a better chance. Also, if there's any other underlying medical conditions that kind of go along with this, as well as how well the patient responds to the treatments that are available out there. Leukemia is typically treated with chemo and radiation therapy. In most cases, treatment does lead to remission. Children with diagnosed acute lymphoblastic leukemia have a 5-year survival rate of around 90%, so the treatment is effective and it's successful in most cases. What we need to do when we're caring for these patients, or when we're assessing these patients, we need to take extra care to make sure that we provide what's known as reverse precautions, because we want to make sure we use those standard precautions, including gloves, masks, and all that, because the patient could actually be immunocompromised, and we're more about, in those instances, protecting them from something that we may bring in with us. Something like the flu or a common cold can be very detrimental to these patients while they're undergoing treatment. Patient presentation will depend on, of course, the stage of their leukemia, where they're at, where the leukemia progression is, and the current treatment plan that they're undergoing. So if they're in the throes of chemotherapy and those kinds of things, we're going to see some different presentations. But typically we see things like fatigue, headaches, maybe some shortness of breath. There could be even some neurological defects going on there as well. The list is pretty long. It covers fever, bone pain, sweating, a feeling of fullness, soreness in the mid part of the chest, and even unexplained breathing. So there's a lot of things that can kind of go with this. That's why it's important to kind of get a history. That way you know that you're dealing with a leukemia patient and not something else going on. Be sure to get a good assessment of vital signs and monitor the cardiac rhythm in these patients, because hypotension and tachycardia are often present and they're a real threat. When caring for these patients, you should provide airway support and oxygen therapy as appropriate. Provide IV fluid therapy and analgesics for pain as indicated and allowed by your protocols. And of course, offer emotional support to the patient as well as their family. You may actually be called to the scene because the patient's condition has deteriorated significantly and the loved ones just have no idea what to do next. In these instances, discuss the situation with medical control because they'll help you provide you with some direction. Make sure you document all of your findings and discussions that you have with medical control as well as the family. And if the family opts not to have the patient transported, be sure to have that refusal or release form signed, before you leave the scene. However, if you do transport the patient, be aware that they could go into cardiac arrest with very little or no warning. Be sure you understand the patient's and the family's wishes regarding what you should do if something like this happens while you're on your way to the hospital. Lymphomas, a little bit different here, changing gears, are a group of malignant diseases that arise within the lymphoid system. They are classified into two major categories. Here's where we see the non-Hodgkin's and the Hodgkin's lymphomas. Non-Hodgkin's lymphoma can occur at any age and may actually have some hereditary natures. It could be genetic. It is characterized based on the disease's progression. There's indolent, which means the disease may never leave the lymphoid system, it's just going to stay there. Then there's the aggressive, which means the disease will progress more rapidly and spread. And then the highly aggressive, this will typically affect multiple organs in a very short period of time. Hodgkin's lymphoma is characterized by painless, progressive enlargement of the lymphoid glands. This most commonly affects the spleen and lymph nodes. Hodgkin's lymphoma is considered a rare form of lymphoma. It is suspected to have some hereditary compounds or elements to it. The incidence typically occurs at two peaks, basically around the ages of 10 and 35, and then again later in life is when this will kind of show up. Hodgkin's lymphoma may have no symptoms for years, but when they're present, they can include things like night sweats, chills, a nagging persistent cough, swelling in the various lymph nodes, a loss of appetite, weight loss, itching, fatigue, and even bone pain. With treatment, remission can occur for long periods of time, and it is even possible to cure the disease with treatments. Lymphomas require specialized levels of chemotherapy and radiation for ultimate treatment. And the patient's response to treatment really depends on the stage of the disease and the classification of that disease. So when we're assessing these patients, we need to make sure that we ask questions like, what type of cancer do you have? And what kind of treatment are you receiving? And how are you responding to that treatment? And questions along those lines so we can get a little more clarification to know kind of where they're at in the process. Signs and symptoms may include pale skin, some congestion in the lower lung fields, the feeling of hot and then cold, or maybe even both in different areas of the body. It's a very confusing sensation for them. Inadequate perfusion or even low blood perfusion. And it's not unusual to see some abnormal EKG rhythms with these patients as well. Pain management with these patients may need to be very aggressive. Treat inadequate perfusion with fluid therapy and provide supplemental oxygen as needed. Watch for and be ready to address any abnormal heart rhythms that may arise. If the condition does not improve or deteriorates, initialize that rapid transport protocol. It's very possible that you may be called to offer support but not transport these patients. When this happens, it's important that you be supportive and understanding. Reach out to medical control and discuss your findings and develop maybe a treatment plan. Explain the options to the patient and the family and allow them to make a well-informed decision about next steps. Polycythemia is characterized by an overabundance or overproduction of red blood cells. This leads to an increase in viscosity and volume. This can result in a congestion of blood in the tissues and organs. This hyperviscosity or thickening of the blood increases greatly the risk of blood clot formation. Polycythemia can be caused by a rare disorder originating in a single stem cell. It also could be an existing disease such as heart failure or hypertension. Could be that the patient lives in high altitudes or has lived in high altitudes for long periods of time, and the body is simply responding to that hypoxic need for more red blood cells. And it's not unusual for testosterone replacement therapy to increase red blood cell production, which can lead to polycythemia. Polycythemia can actually lead to other conditions, more serious conditions like strokes, TIAs, deep vein thrombosis, pulmonary embolisms, MIs, headaches, and even abdominal pain. Clinical treatment usually includes phlebotomy, which is draining or donating blood to maintain those normal hematocrit levels. Other treatments may include cancer type therapy treatments to kind of get the red blood cell production to kind of slow down. During your assessment, the findings can vary widely, and they may include things like an altered LOC, hypoxia, there may be some respiratory distress, changes in peripheral pulses, pulse rates, and even skin color from one extremity to the other extremity, and possibly even tachycardia. Be sure to take note the extent and duration of the shortness of breath due to the risk of a pulmonary embolism. Inquire if the patient has experienced uncontrolled itching. Ask if the patient has noticed any changes in their skin temperature. And of course, make sure that you obtain a thorough medical history along with all medications that they're taking. Management will initially focus on whatever their chief complaint is. That's kind of the rabbit hole we'll go down initially. Although the underlying pathology may be polycythemia, the patient may be experiencing a different medical emergency, so don't automatically assume it's the one thing. Otherwise, we're going to provide supportive care and transport to an appropriate facility. Remember, administer oxygen as needed. They typically have a very good oxygen carrying capacity, and that's not usually the problem. But be sure to establish an IV for possible pharmacological interventions, either by you or by the hospital when you arrive. Disseminated intravascular coagulation is a condition where blood clots are excessively formed in the body's blood vessels. This can be caused by a number of life-threatening conditions. This disease typically progresses in 2 stages. In stage 1, we have the free thrombin and fibrin deposits in the blood increase, and then those platelets will start to aggregate, and then the breakdown of the fibrin clots occurs. In stage 2, where uncontrolled hemorrhage results from a reduction in those clotting factors. The mortality rate with these patients is really hard to determine because patients often have additional conditions that are kind of going in along with this. However, death is typically related to uncontrolled bleeding, hypotension, and shock. So these are the ones we want to watch out for, that weird signs and symptoms of shock when other things don't add up. Assessment should be focused on identifying signs and symptoms associated with disseminated intravascular coagulation or progression toward it. Patients may exhibit episodes of respiratory difficulty, signs of shock, and even skin changes. And these are the clues that we really need to pick up on quickly. Management should include, of course, maintaining a good airway and administering supplemental oxygen. We need to keep a really close eye out for signs of developing shock and treat it accordingly. Of course, be ready to provide pain management treatment and of course treatment for those any abnormal heart rhythms that may arise. And our approach to the family and the patient should remain optimistic but honest about what's going on. Hemophilia is a bleeding disorder in which clotting does not occur or occurs poorly. This particular disease is actually associated with X-linked regressive genes. It is classified into two primary types. There's the type A, which is indicated by low levels of the anti-hemolytic globulin and anti-hemophilic factor. And then there's type B, it's a deficiency of plasma thromboplastin, plasma thromboplastin component. Not important that you remember those. Hemophilia is primarily found in males. Now, the levels of the factors, those factors 8 and 9, which I just mentioned, determine the severity of the disease for that particular person. So signs and symptoms are the same in both types, and they may include acute or chronic bleeding and sporadic intracranial bleeding. Patients with significant acute bleeding episodes may actually require hospitalizations for blood transfusions, or maybe including infusions of those factors 8 and 9 as mentioned that they have the deficits in. Assessment, of course, is going to be a good evaluation of the ABCs and to be on the lookout for signs of acute blood loss. Pay particular attention to any bleeding of unknown origin and watch for developing signs of hypoxia. Administer oxygen as necessary. Remember to keep an eye out and note any abnormal EKG findings. Treat symptomatic dysrhythmias according to that particular protocol and provide IV therapy if required. Analgesics may be appropriate for pain relief with these patients if needed. Not all of them will need it. Keep patients covered to maintain their body temperature. And if the bleeding is stopped before your arrival, recommend that the patient seek immediate follow-up care either in the emergency room or with their primary care provider. Multiple myeloma. With multiple myeloma, there's an abnormal increase in plasma cells in the bone marrow, which leads to tumor formation. This abnormal activity impairs normal bone marrow function and causes decreased production of red blood cells, white blood cells, and platelets. So it kind of slows everything down. As a result, the patients may experience anemia and an increased susceptibility to infections, as well as an increased risk of bleeding. With multiple myeloma, the neoplastic cells can also increase protein production in the bloodstream, which can result in organ failure across the board. The disease primarily affects patients over the age of 40. As the disease progresses, patients may experience bone weakness, which can result in spontaneous fractures, and the patients often report pain in the bones and the back. In advanced cases, treatment options may include stem cell transplant, chemotherapy, and even radiotherapy. Radiotherapy. I thought it said radiation therapy. Follow standard precautions, including wearing masks and gloves to ensure safety for patients with multiple myeloma. Assessment findings may vary depending on the stage of the disease. In early stages, patients may mainly report fatigue or mild pain. However, in later stages, signs may include things like unexplained bleeding, significant weight loss, frequent bone fractures, and pain from multiple locations. Management will include the administration of IV fluid therapy as needed, and of course consider providing pain relief or pain management if necessary. The primary focus should be on supportive care for the patient, and of course be sure the patient is transported to a hospital capable of managing their condition whenever possible. Transfusion reactions. This last one we're going to talk about in this section here is transfusion reactions in about 0.2 to 10% of all blood transfusions, so they don't happen very often. They typically resemble what we would see in the classic anaphylactic reactions, and that's because they occur rapidly and they can lead to severe circulatory collapse and even death. So they look a lot like an anaphylactic reaction. However, but it's important to keep in mind that not all of them go that severe pathway. Some of them can be very mild. Always closely monitor patients receiving blood or blood products for at least the first 30 to 60 minutes, or obviously as long as they're in your care. A reaction can occur if a patient receives a blood type that differs from their own, or a blood type with a differing Rh factor, or even if the blood contains allergens that patient, the receiving patient, is allergic to, that was in the blood of the person that was making the donation. So there's a few reasons why we can have a reaction. Of course, this table shows the A, B, O, and Rh blood types and the preferred donor types, preferred and alternate donor types for these. One of the things I want you to notice in this is the number of times O negative blood is in this table, because O negative blood is actually a universal donor. So it's often seen as the savior of all that need blood. However, it's really important to point out that O negative donors only make up about 7% of the population. So it's not really a viable source for the other 93% of the world that may need blood. The 7%, there's just not enough of them to go around. Therefore, most patients receiving emergency blood transfusions will receive O positive blood, because O positive donors actually make up north of 40% of the population. I want to say it's around 46 to maybe 48% of the population. And O negative blood is a viable alternative. While there still is that risk of the Rh factor, the plus or negative on the blood type, there's still that risk of a reaction with that. But recent studies have shown that risk to be relatively low, and the reaction from that is not as severe, meaning that Rh factor issue with type O blood can be managed. So in the pre-hospital setting, we're seeing O negative blood being given in the field primarily to trauma patients, but we really look for that to begin to happen with medical patients in the future, especially some of them that we've talked about in this chapter that have blood disorders and blood issues, and the last chapter when we talked about GI issues and the potential for blood loss there. So that's why I wanted to spend a little bit of extra time on the transfusion reactions, because while administering blood in the field for a paramedic is not really common practice just yet, it's coming. It's coming more and more places. Oklahoma City, Dallas, Shawnee, even here locally, is now giving blood in the field. So it's important to kind of know these things about it. And for many, many years, paramedics have been transporting patients with blood products. So that's nothing new there. So it's important to kind of understand a little bit more about this, because it is something that is emerging. Signs and symptoms of a reaction can be subtle, especially in those patients that are unresponsive, intubated, or especially in trauma patients, because some of the reactions that patients might have is very similar to what you would expect a patient to have if they had a low blood volume and we needed to replace blood. So during an acute reaction, we want to look for a few things. The patient may experience a rapid onset of chills, fever, back pain, vomiting, tachycardia, and hypotension. Tachycardia and hypotension we would expect to see in a hypovolemic patient that's receiving blood. However, fever, chills, back pain, and vomiting, that is not normal. And in the unresponsive patients that can't tell you that they're chilling and they have back pain, then those patients, keep an eye out for signs of developing skin rashes and hives that can be kind of the standard telltale sign that there's an infusion reaction going on with them, because as mentioned, the other signs and symptoms may be masked because the patient's unable to communicate those with you, or they're hidden by, we already know they have low blood pressure or those kinds of things. But if the blood pressure continues to drop, we don't know if that's because they're continuing to bleed out or if they're having an infusion reaction. So we have to look for these other signs and symptoms. Also realize some of these, if it's an ABO, if they're absolutely given the wrong blood type, some of these reactions may take up to 7 days to show up. So it is entirely possible that you could be transporting a patient that received blood a few days before that now begins to have an infusion reaction. Murphy's Law works. They're going to have that infusion reaction, transfusion reaction while they're with you for that 1 hour window in the ambulance or 15-minute window, whatever it is. So it's important for you to get that good history to find out what's been going on, and that might be an indication that they're having a transfusion reaction. Complications of transfusions can be categorized as follows. They may have a hemolytic reaction. This actually poses the greatest threat during blood transfusion. It's primarily caused by that incompatibility between the recipient's and the donor's blood, and the recipient's immune system begins to attack the new red blood cells, destroying them. And what I mean is by incompatibility is say type A is given type B blood, that's going to cause a hemolytic reaction where the recipient's blood is going to try to destroy every one of those red blood cells because it's seen as foreign and a threat, because it just doesn't match. Then we might have a febrile reaction. This is the most common. It's usually benign. It's usually not a problem. An isolated little small increase in body temperature or fever. It's not necessarily a serious or dangerous transfusion reaction. Typically, these are treated with some fever reducers and observation for more serious reaction beginning to develop. Now, we could have an allergic reaction. This involves an anaphylactic response to preservatives or other agents in the transfused product. The other agents could literally be something like the donor blood. The donor maybe ate a peanut butter sandwich the night before they donated blood, and the recipient is allergic to peanuts and they have an allergic reaction. Or it could be from the preservatives or something else used to keep the blood safe and for it to last longer. This usually occurs within the first few minutes of transfusion, and it will present with those classic signs and symptoms of anaphylaxis. These are those that in our unresponsive patients, we're going to see them cover in a rash, and all of those kinds of signs and symptoms will be readily apparent, fever and all that. And then we're just going to jump on over to that anaphylactic protocol, and we're going to treat that patient that way. We'll talk a little more about what we do with the transfusion reaction, here in a minute. But then there might be a transfusion-related injury. This is a non-cardiogenic pulmonary edema caused by an increase in capillary permeability after a transfusion. Of course, treatment's really going to focus on ABCs. If it's a lung injury, we just want to make sure we take care of those ABCs. There could be a circulatory overload. This oftentimes happens in patients with existing things like cardiomyopathy or a ventricular dysfunction. Treatment's going to include some diuretics, oxygen, maybe some nitrates, and morphine to relieve excess fluids off of that patient because they got overloaded. And then there even could be a bacterial infection, but this usually results from poor handling of blood products or some kind of contamination during the infusion. But realize this can quickly lead to sepsis. Now, this doesn't discount the fact that there could be some bacteria present from an infection that the donor had as well. So there are inherent risks to administering blood to a patient. And the risks go up exponentially, especially if we have those patients that are immunocompromised. The risk becomes a lot greater. Of course, the severity of the reaction often correlates to the volume of blood that we transfuse. The more blood you give, the greater the reaction is going to be. So that's why it's really important that we stop administering the transfusion quickly. We can limit the severity of the reaction by stopping that transfusion. Of course, we may need to reach out to medical control for a little extra guidance on how to proceed. Say you're transporting a patient and you've got 1 unit of blood they've had a reaction to. You've got a second unit of blood. You might need to reach out to medical control and see if they want you to switch to the other unit of blood or not. We don't know. That'll be their decision. Providing supportive care to counteract shock. Watch out for that. Remember, if we're administering blood because we've got a shocky patient and now we can no longer administer it, all of those things that we were going to try to stave off, we are no longer going to be able to do that with the blood products, so we're going to have to pick a different route. Of course, as I mentioned, treat those anaphylactic reactions according to your protocol. Just flip over to that protocol and begin treating it that way. Replace the existing tubing with a bag of normal saline. So we want to, don't flush that blood into the patient. Literally switch the tubing out with fresh tubing and flush it and then flush saline in there. Don't want to push any more blood product into that patient than they've already had. And of course, always, always, always retain the blood products and tubing so that you can give that to the hospital. Keep that with the patient. On those bags of blood, there's some very specific identifiers that identifies, not only that bag of blood, but who donated it, what facilities it went through, and there's just a whole chain of how that plays out. Never, ever, ever throw away an empty bag of blood. It always stays with the patient, always, no matter what, because that's part of that record and it just follows right along with that patient. The Blood Institute does other research with that. They can backtrack that blood and make sure that, what may be going on with that patient if they had an infusion reaction, because they want to try to avoid those things in the future. Okay, so very, very good. That is the end of, oh my goodness, I forgot what chapter we're on. Chapter 24, maybe? I don't remember. That's the end of part 2, dealing with hemolytic emergencies. I'll be back at the next chapter.